Welcome everyone to our fourth webinar of the Future of Health Systems series, Building Resilient Health Systems in a Changing World. The app-led transformative discussion series explores emerging issues critical to strengthening health systems with communities in a post-COVID world. My name is Amanda Quintana, and I am APP's Climate and Health Technical Lead, a PhD candidate at the London School of Hygiene and Tropical Medicine, and the moderator for today's webinar session. Wherever in the world you are joining us from today, you may be aware or have experienced one or several of the many evolving challenges and stressors our health systems face. Today's health systems must adapt and respond to and take on everyday and intensifying challenges, such as those tied to climate change, infectious diseases, and conflict. A changing climate seen through increasing temperatures and frequent heat waves, floods, and extreme weather events such as cyclones, as well as emerging infectious diseases, have direct and indirect impacts on health and health systems patterns of use, and amplify existing systemic vulnerabilities and inequalities. The health sector's ability to sustain the health of communities and effectively respond to these varied challenges relies on the resilience of our health systems and their ability to prevent, prepare for, detect, adapt to, and respond to, and recover from public health threats, while ensuring quality essential and routine health services. So with that extensive introduction, I'm so very excited to dive into this topic with our esteemed speakers. First, I'd like to introduce Maureen Barty, who's the lead of the Public Health Systems Unit and Senior Advisor for Health Systems and Health Security in the Bureau for Global Health Security and Diplomacy at the U.S. Department of State, where she leads work to strengthen public health systems to respond to HIV/AIDS and contribute to their ability to address other ongoing and emerging health threats through the President's Emergency Plan for AIDS Relief, better known as PEPFAR. She has more than 25 years experience leading, managing, and implementing public health programs and policy, both domestically and internationally, working on the U.S. response to numerous public health emergencies, including the 2022 Uganda Ebola virus outbreak, monkeypox epidemic, COVID-19 pandemic, the 2014-16 Ebola outbreak in West Africa, and SARS. Next, we have Krish Navalabji, who has worked for over 41 years in the public health sector before retiring in September 22. He is a qualified medical doctor with a wealth of experience in clinical medicine in urban, rural, primary healthcare and hospital settings in KwaZulu-Natal province of South Africa. Dr. Valabji went on to specialize in public health and was appointed to the South Africa Western Cape Department of Health, where he has held a range of positions from Director of Policy Planning, Emergency Medical Services and Forensic Pathology Services, to Chief Director of Strategy, where he worked in strategic planning, health impact assessment, quality of care, and information system. He now works on as a consultant for Clinton Health Access Initiative and currently supports the National Department of Health in South Africa to develop their next 5-year strategy for district health systems. And finally, we have Susanna Mayhew, who is Professor of Health Policy and Systems and Reproductive Health in the Department of Global Health and Development at the London School of Hygiene and Tropical Medicine, better known as LSHTM. She also serves as co-director of the LSHTM Center for Maternal, Adolescent, Reproductive, and Child Health. And Dr. Mayhew's research specializations are in policy analysis, policy implementation, governance, and accountability research, including community engagement, health systems, and systems integration research. She has led multi-partner research projects in numerous countries across sub-Saharan Africa and Southeast Asia, and at present works primarily in West and East Africa on cross-sectoral responses to climate and health challenges, including reproductive health and zoonotic disease outbreaks, with a focus on community engagement. Welcome, and thank you all for joining us today. Each speaker brings a varied perspective to health systems resilience. We have donor, academic, and implementation. We are really excited to learn today, is there a common approach and views to health systems resilience? To get us started, our first question to the speakers is, what does health systems resilience mean in your work? I'll hand it over to Maureen first.
Well, thank you so much, Amanda. It really is such a pleasure to be here and to participate in this really important discussion. Thank you for convening us. To answer the question, I think for the President's Emergency Plan for AIDS Relief, or PEPFAR, health systems resilience means that health systems can ensure that essential HIV prevention, treatment, and care services continue even during other health crises, such as infectious disease outbreaks and pandemics. And resilience also means planning to ensure that systems are equipped to deliver during future challenges, that there's a strong and sufficient workforce that can be mobilized rapidly during crises, and financial mechanisms are in place to access resources when needed. The leaders of PEPFAR, from its inception in 2003, recognized the centrality of resilient health systems to the relative strength of a country's response to HIV, and included work to strengthen health systems while delivering life-saving treatment to those living with HIV. And throughout its 20 years, PEPFAR has invested in the health systems of our 56 partner countries around the world. And that includes by strengthening laboratories, surveillance systems, supply chains, the health workforce, national capacity building, and infection prevention and control. And all of these are essential elements for effective, strong, and resilient health systems. But resilient health systems are more than strong health systems. They also require political commitment. And that's why Secretary of State Blinken, along with Ambassador John Nkengasong, in August launched the Bureau of Global Health Security and Diplomacy, which is mandated to lead US diplomatic engagement to strengthen the global health security architecture and prevent, detect, and respond to infectious diseases. Also to leverage and help coordinate US foreign assistance and promote international cooperation to better protect the United States and the world from health threats, and to elevate and integrate global health security as a core component of US national security and foreign policy. And we think these elements together really will contribute to, I hope I didn't lose you. Okay, will contribute to strong and resilient health systems in the future. Back to you, Amanda.
Thank you. I'll pass it on to Susie.
Thanks, Amanda. And yes, it's great to be here in this important discussion. So from an academic perspective, there's been a variety of academic work over the years to better understand what health systems resilience means, which builds on our understanding of what a health system is, and that for a health system to function well, it's determined not only by what we call systems hardware, which is many of the things that Maureen was speaking about, infrastructure, funding, trained staff, also encompasses policies, but it also includes systems software, which is about the relationships of people within the system, between people within and across different levels. And in terms of resilience, a lot of attention has been given to the hardware elements. How can financing for health systems be secured? Do they have available information on how climate is changing disease prevalence so that we can plan? Are the disaster protocols in place? That sort of thing. And there's also work, particularly from South Africa, which I think Krish will speak more about, on the need to build everyday resilience, which is about how the people within the system at local management and service delivery levels support each other to cope each day with whatever challenges they face. But I think what's been most neglected in the academic health systems resilience discourse is a wider understanding of health and well-being as something that goes beyond the health sector, and that healthcare is something that actually happens within families and communities who don't live in siloed worlds. And the Ebola and COVID pandemic outbreaks, I think, really underlined how important it is for health systems to be able to connect with grassroots and frontline health workers if they're going to be able to respond rapidly and effectively to large and often unpredictable crises. And that's what truly builds resilience of a wider health system. Back to you.
Thank you. And Krish, over to you.
Thanks, Amanda, and hi, colleagues. Also great to be here. So I think my fellow colleagues have largely covered it, but in my perspective from a implementing agent point of view, from a provincial point of view, it's largely a kind of capability at individual, team, and organizational level to try and address the various kind of shocks and stresses coming at us, the adversity that comes at us, and to try and emerge on the other side as a stronger unit. And that adversity and shocks and stresses, like Susanna has said, could take various shapes and sizes. I mean, every day, there's a term we coined here in the province of a burning platform because of the service pressures on a daily basis, relentless service pressures. And that in itself requires resilience. So over and above that constant high-pressured situation, you have superimposed on that a whole lot of adverse events. And in the province here, we can recollect we've had load shedding from the last decade or more, and it got worse in the last couple of years, where we've had electricity cutouts and with huge impact on health services. We've had a drought in 2016, 2017, and Cape Town was, came to day zero very, very, very narrowly. We've had a range of fires over the years. We've had a range of floods, including this year. And of course, then the pandemic that came and really was, at another scale completely. And of course, we're thankful, but we're not in a kind of conflict or war zone, but you could think of places like Ukraine or Gaza, etc. So there's a whole range of adversities that come at us. And the question is, how does one address that, and how does one emerge stronger on the other side of it? I mean, there's a clear sense that this adversity and stresses and shocks are becoming more frequent, are increasing in scale and severity and its impact. And therefore, this question of resilience becomes a highly important one of how we address it systematically. And so when we're talking about capability, we're talking about systems, we're talking about processes, we're talking about skills and competencies. Like Susanna has said, softer issues like relationships, partnerships, collaboration, connectedness, all of that making a capable health system to try and withstand these pressures. Yeah, thanks.
Thank you for sharing your perspectives. It's really clear that health systems resilience carries different meanings depending on the context, but we acknowledge here on this webinar that there are everyday challenges that we need to consider, from infectious disease outbreaks, extreme weather events, and conflict, to long onset stressors such as climate change, societal and economic stressors, and changing disease patterns. So there's a slew of things to consider. Could you please discuss some principles, activities, or interventions that have contributed to building health systems resilience? Specifically, how are the most marginalized and vulnerable populations included in such principles or interventions from your experience? I'll open it up to anyone who'd like to raise the first point.
I can talk from the experiences of the work that we did most recently in West Africa and the Ebola response. I think Maureen was also involved in that actually, but obviously we were from the academic side. So we were looking at early affected districts that had to respond to this particular crisis before there was a formal response and before there was international resourcing really coming in. And the key insight, I suppose, was that in a crisis, whether it's an acute crisis like a pandemic outbreak or a climate event, or a slow onset burning platform type crisis that Chris referred to, I think the first responders are always going to be the individuals affected, their immediate families, their immediate communities, or in a systems setting, then your immediate colleagues. So just reflecting on the work that we did in those frontline districts in Sierra Leone in relation to building resilience for crisis response and early warning specifically, from that work, I'd just highlight three things. First, the need for the response agencies, including government, but also foreign climate crisis responders, to learn from, to listen to, and to work with frontline health workers. And one stark example of that from Sierra Leone was that it was the frontline health workers who realized within the first month of Ebola cases being found in Sierra Leone that the symptoms there were different from previous outbreaks. There wasn't very much of the classic bleeding. And so they warned their local health network teams that they needed to be prepared that people coming in apparently with malaria or cholera actually may well have Ebola, and they changed the local protocols to improve infection control. But it took 6 months to change the formal guidance on that. So lots of infections were missed in those early months, which need not have been if the local frontline workers have been listened to. And that's a hierarchy issue within the health system. The second is that breaks down trust, and without trust, you don't get people complying with what you want to put in place for infectious disease control, contact tracing and reporting of cases and quarantining and so on. But related to that, you really need to be able to work with people who are both embedded in communities, but also connected to the health sector in a way, in a trusted capacity. And those are people like embedded health workers, community health workers, but also local leaders. So any response mechanism won't be resilient without local buy-in. And we saw this in the UK as well during COVID, where there was a complete breakdown in trust of the government, and people basically made up their own rules about how to keep themselves and others safe or not. And finally, making use of opportunities to work with existing structures where they are in place, community groups, local decision makers, and they can be used for a whole variety of things. For example, infectious disease control, contact tracing, as they used in Sierra Leone, volunteer networks locally who were more trusted, so people would report. In the UK, we had volunteers signing up, but they weren't used. They can be used for early warning for zoonotic outbreaks, potentially. So, for example, in Sweden, they're piloting local bird watching groups reporting deaths of wild birds. In Cambodia, pig farmers can report deaths of their pig stocks direct to the Ministry of Agriculture, who shares with the Ministry of Health in case it's a potential zoonotic hazard. But you need to build sector coordination at the ministry level as well to engage and share that sort of information. And you can also use frontline people to build up data on emerging patterns of chronic climate change and seasonal change and rainfall, which might affect food and nutrition outcomes, but also where you're seeing new diseases emerge. So some of the people we're working with in rural Uganda are reporting malaria where previously there wasn't any. So early warning, early information coming into the health sector from communities can be invaluable in starting to plan for a response. But you have to have a joined up process and probably structures and certainly responsibilities within the health ministry, but also across other relevant ministries to share information and actually act on that. So frontline work, but also coordination across sectors are both really key, I think.
Thank you so much.
Maybe I'll just jump in to add to what Susanna has just shared. I think, you know, PEPFAR and the HIV response probably has some lessons, you know, to share with others for how communities have been engaged. And certainly with the HIV/AIDS response, you know, it has been incredibly important to work directly with the affected communities and really making sure that members of these affected communities are in the lead of designing solutions to the response. That includes access to expanded testing and treatment and retention and prevention services. And I think, you know, we should be thinking about the mechanisms that have been put in place to engage with community members at the national level, regional level, and community levels. But I think that we could learn some lessons and that could help with resilience because, you know, in terms of HIV/AIDS, it really thrives among the most marginalized populations. But these populations are also those who end up being oftentimes at the forefront of vulnerability for other disease threats. And so how do we ensure that we're continuing to listen and to follow their lead, you know, as we design these resilient systems? I think also, you know, thinking about how public health infrastructure that might have been put in place for a specific disease like HIV could be leveraged for other response to other disease threats, and really think about how we do this very intentionally as we go forward. So specifically for PEPFAR, we've supported laboratory infrastructure. And that laboratory infrastructure is used not only to diagnose, treat, and monitor HIV, but also used for other diseases. And in fact, many of the PEPFAR supported HIV testing platforms were used for COVID-19 testing when the pandemic first started. Also thinking about infection prevention and control, and that is a universal need. And so are there ways that we can ensure that infection prevention and control activities are executed not only for disease-specific programming, but also just across the board and when we're working with our local frontline health workers. And then I think also just thinking about innovations. A few innovations were put in place through PEPFAR that have really helped access to HIV drugs. They were put in place for COVID, but I think it really, these are innovations that I think could be helpful as we think about the resilience of the health system. And this includes multi-month dispensing of medications. So making sure that, members of the community don't have to come and access their medications, so regularly, but rather they're given, many months of medications at once. And also bringing touch points and places where they can access their medications closer to the community. And so really thinking about marginalized populations and where do they receive services? How do we make sure that where they can access medications and treatment is brought to them, so that rather than sort of, setting up these static points and expecting everybody to come to those points. And I think that also then leads to the stronger and more resilient systems, because we can adapt as threats, some of the threats that Krish mentioned, fires and earthquakes and other threats. If you have more adaptable systems, that can really help to ensure that the essential health services can continue during those threats.
Absolutely. And Krish, over to you.
Thanks, Amanda. So yes, I think colleagues have brought some important points, and they're speaking from a service platform point of view. I think the first point I'd like to make is that building resilience starts much before the crisis hits you, right? And it's really about investing in systems and strengthening systems if there is such a thing as quiet or normal times, right? But you really got to invest in that, because in our experience in the Western Cape, what we've invested over the last 20 years or more held us in very good stead during COVID. Right? And we were able to respond reasonably adequately and achieve a lot because of what we had built. And again, both hardware and software, relationships and structures and governance arrangements and all of that. And, in our context, governance is a big matter, and we were very proud at the end of it that we even achieved a clean audit in the middle of COVID, because for many of our sister provinces and the rest of the country were not able to do that. Right? So I think it speaks volumes of what you invest before the crisis hits you. From a COVID point of view, several lessons. I think Susanna has already spoken about working across sectors. Now, we in health, conventionally, we are used to health service provision, okay? And that's been our core business. This is actually calling for a new set of skills. It's calling for a different competency to try and step up beyond health service provision to provide stewardship across sectors, right? And harness a whole lot of forces for common good, right? And that's a very different skill set. Negotiating the power dynamics and the differentials, etc. So stewardship is a big factor. Then when it comes to leadership itself and management, I think distributed leadership at all levels of the system. So we're not only talking about senior level or top management, right across the system, because leadership at ground level is critical in terms of achieving and being responsive. And that leadership, again, attributes as being humble, being vulnerable, and acknowledging that we don't know all the answers. That because when COVID came, there were many things we did not know. We were finding our way through it, right? And to be humble enough to acknowledge that, right? And to be able to listen and learn from a variety of perspectives, from the people on the ground, from our academics, experts, etc. So I think those attributes are very important, but also then being supportive to the frontline staff who are in the trenches and who are bearing the brunt of what adversity is coming at us. The issue of flexibility and agility is and one of my colleagues have mentioned it, very important. I mean, we surprised ourselves as a government bureaucracy of how responsive we can be, right? And in Cape Town, we used the Cape Town Convention Center and converted it into an intermediate care hospital, an 860-bed intermediate care hospital. And that took us about 6 weeks to do that and fully staff it and have it operational. Now, I know there might be some countries like China and others who could do this in a few days probably, but for us, 6 weeks was unimaginable previously, right? And to have that, so it just shows that governments can be responsive and can do amazing things. And we didn't break any rules. We still did it. We didn't. People often use bureaucracy as a reason why we can't be responsive. So flexibility and agility highly important. Then the issue of collaboration and connectedness. I mean, as a health system, there are so many moving parts, and if you add to that other sectors, it's a number of moving parts. And how do we remain connected and leverage the power by working together and being connected? And in there lies a whole lot of hardware and software that Susanna talks about. The issue of sharing information, trust, communication, all of those things are key, both inside the health service as well as external partners as well, whether it's universities, other sectors, etc. Then I touch on caring for staff. So it was a big thing that COVID, brought right up, and we all say staff are important, but in COVID, we just recognized what it takes, what toll it takes on staff. And not only just the provision of PPEs and the kind of hard stuff, but the mental and emotional turmoil and brunt that it bared on our staff, who were, never seen so many patients die in their care in such a short space of time. And then families and friends and communities also having that. So to try and operate under those circumstances called for a different level of emotional well-being and support. So caring for staff, highly important. Agile governance arrangements. So we know all our structures have our usual management structures, etc. But this called for, at the peak of some of the waves, the top management team met twice a day, right? And it really required a very flexible kind of arrangement. Huddles became the go-to mechanism for quickly taking stock and making decisions, and huddles with clinicians, managers, technical experts, all coming together very quickly to try and respond. The use of evidence and data was also a big learning for us. As busy managers, difficult to cope with the amount of evidence that was coming at us, right? And therefore leveraging the expertise in our academic institutions, setting up collaboratives. We had a collaborative for vaccines, we had a collaborative for occupational health, for behavior change, for surveillance and testing. So all of those agile structures to try and support decision making. And then the last point I would make is communication. Highly important, not only for inside the health service, but also public communication and messaging became hell of important. And we had weekly briefings, press briefings and media briefings with our premier, head of department, etc. And those helped to build some level of trust with the public and communities in terms of sharing information, acknowledging what our challenges are, etc. So Amanda, that's probably a short run of the number of things. I'm sure there are many more. Thanks.
We'll have more opportunities to add on to the list of it, but overall, I feel that our audience has definitely taken away some very important lessons from all of you and your experiences that you've shared. I'm hearing a lot of the importance around trust and communication, working with our frontline workers, distributed leadership, you know, community surveillance. I mean, the list is on and on. But a big takeaway for me is that in times of crisis, we really can learn. And those learnings are really important to capture so that we can actually build these resilient health systems. You know, recovery, learning, and evaluating past experiences allows us to prepare for future situations by rethinking the health system and how it can be made more resilient. And literature on health systems resilience has indicated that adjustments to long-term changes and the element of learning should be considered for a better understanding of health systems resilience. So from your experiences, how can we best address learnings in the health system? Please share any examples from your areas of work, but if you would also like to respond to what your other panelists have spoken about today, feel free to. Thank you. Anyone can jump in first.
I'll jump in here. Just maybe to highlight something that Krish mentioned in his last comment, just about the importance of data and the importance of partnerships with academic institutions. But maybe to take it just a little bit further, I do think, you know, as I was working in the White House at the time of the COVID, part of the time of the COVID pandemic, there was so much data coming through, but sometimes it wasn't presented in such a way that you could make decisions. And so, you know, really thinking when we're not in a crisis mode, how do we get partnerships with academia, government institutions, private sector together to think about how we use data and bring data together for decision making, but present it in such a way that it can be most effectively used for making those decisions. And I think that's sort of the need to bring policymakers, you know, together with academicians and really thinking about what do the policymakers need to know. You know, these decisions, as Krish was mentioning, 2 huddles with leadership, you know, per day was not uncommon, and decisions were needing to be made at all of those meetings. And usually in academia, we take our time in analyzing our data and all of our caveats and everything about our data, but that's not, we can't, we don't have that luxury during crises. And so I think we can learn from, you know, the crises we've seen so far to really adapt and think about how do we put in place these better collaborations and consortia to think through how to most effectively use data for decision making. I also think the caring for staff that Krish mentioned is just so incredibly important. And I do think we have to figure out how we do a better job of caring for our staff throughout the before crises occur and afterwards. Make our staff, our frontline health workers feel valued and understood and support them, especially with mental health resources. I think we have played some lip service to that in the past, but the COVID-19 crisis has really brought about the need for this. And so really thinking through how do we put these resources in place now and have them available all the time so that these are normalized as well and resources that people use all the time, not only during crises.
Susanna, did you maybe want to jump in and also comment on the academic processes and I guess how building evidence takes time, but ways that it can be in real time?
And I think it's interesting that we've all given examples of how health systems have, in the face of crisis, managed to adapt, to bring in new processes, new structures, talk to different people from normal, being flexible, being agile at different levels. And clearly that's a characteristic that's really critical for a resilient health system. From an academic perspective, it's not easily measured, and it's quite hard to know how you build the skills for that, because there isn't, by definition, there can't be a blueprint, because you'd be imposing something that was too rigid. You have to be flexible. So And it's almost more about the building of key skills. And I guess from the work we've done, I think breaking down hierarchy is really important. You know, we work in sectors that are incredibly hierarchical. The medical sector is hierarchical, government is hierarchical, crisis response is a hierarchy. You know, by definition, systems have a hierarchy. But I think Chris talked about being humble to, you know, learn from others, work with others. Support, both Chris and Maureen talking about the support to health workers on the ground. So how do you do that? Some of that, we talked about distributed governance or distributed leadership. So structures and lines of authority themselves may need to change. So that is structural to some extent. We need to devolve resources. We need to devolve decision-making authority to allow decisions to be taken closer to where the effect is happening, because that makes it more agile. But fundamentally, the change is about a mindset change, I think, whereby the local is understood and respected for being relevant and important and able to make rapid decisions. Because, as I said before, people on the front line, we don't live in silos in our real world. You know, the climate is connected to our health, and so on. And I think that the system software, the people in a system, can overcome certain structural barriers. Work I did quite a long time ago now on sexual and reproductive health in sub-Saharan Africa, looking at integrating very vertical programs, showed that even where you had vertical program structures that were quite rigid and siloed, if you had committed frontline staff willing to rethink how they were caring for the patient in front of them who had multiple needs, and those staff felt supported, then they could provide integrated joined up care, even if the structures made it appear that they couldn't. They would find a way. So it's about building those software capacities, I think, of agency, cooperation, negotiation skills, teamwork, leadership skills, all of those soft things which are harder to quantify, but I think are really key to building that resilience and creating a system that is flexible and able to adapt to unpredictable things, whether those are acute crises or chronic slow onset crises. And we need to give, from an academic perspective, we need to spend more time, I think, understanding how we can support the building of those sorts of skills and how we can measure them, because somebody said to me once, if you can't measure it, you won't get money for it. So there is a certain amount of sort of academic rigidity. We need to look at what we're measuring so that we can advocate for funding to build that resilience.
And actually, in just a few moments, we'll jump to the chat with questions from the audience, but there is a question around measurement that I might pose to you all. So over to you, Krish, to respond.
Thanks, Amanda. So I completely agree that, learning it's central, and it's really, like you've mentioned, the evidence shows that, health systems that pay attention to learning and learning culture and systems actually perform better. So learning is not a luxury, and sometimes because we are so busy doing so much, we think learning is a luxury, but it's not actually. It's actually an essential feature of building our resilience and our capability. So I think that's an important thing. The second thing is, it's not a function for some kind of directorate or component in a corner of the organization. It's everybody's business. And how do we build learning into the culture of the organization? And when we talk in learning, of course, there's a place for formal training courses and the like. But what we're mainly talking about is how do we learn in daily practice, in the workplace, right? And use every day, every opportunity to reflect more deeply, make better meaning, and learn from it. And that's critical to building our organizational fitness for resilience. Right? I mean, we've spoken about, I've just quoted examples in my introductory comments about the number of adverse events that have come at us. And being intentional about learning from each one of those helps to build the organizational fitness going forward. So I think learning can't be emphasized enough. Now, the role of leadership in learning is important because leadership really needs to role model and signal the importance of learning. And they need to set examples in the way they conduct themselves, right? And creating a safe environment for learning is, however, important. A safe environment meaning where we are able to have honest, frank conversations, where staff can openly criticize, constructively criticize, right, or raise different perspectives and not be afraid to do so. And leadership being humble enough to hear different perspectives and take advice and listen to the experiences from the ground. So creating a safe environment is hell of a important. Now, management and leaders are hell of a busy people in health systems. So if we went about creating a whole set of parallel structures and mechanisms to learn, they would unlikely succeed. Right? So we need to build it into existing places and spaces. Every management meeting is an opportunity to learn. If we restructured the agenda, we made it less busy, we had fewer items, and had changed the quality of the conversation, allowed for some unstructured conversation, allowed for reflection, etc. An example from our local province was M&E meetings. That we used to spend several hours doing M&E where we checked on indicators and whether we met targets and why not, etc. And it's a compliance requirement. But we used the same amount of time and we contracted the amount to tick the box, so to say, for compliance purposes. And we used the bigger part of the meeting for a deeper dive into focus areas, right? And there we changed the audience. We brought in clinicians, we brought in people from different levels of the service, and we had a deeper dive, whether it was maternal health or violence or whatever it was. And the quality of those conversations were so rich, and there was so much of learning in there, right? So it's an example of using our existing spaces and places more effectively. In the COVID period, we created a strategic huddle once a month, right? Where we stepped away from the busyness of everyday matters and just reflected on particular aspects. And it was attended by 150, 200 people on a virtual call from all levels of the service, right? And I'm glad to say that meeting, that strategic huddle, has now been sustained. In fact, just on Monday this week was the November one. So it's the first Monday of every month. So it's an example of how to create these opportunities and sustain them for a very important aspect of learning. Sharing experiences across platforms also however important. And we as management and leadership must create the mechanisms for that to actually happen. Lastly, how do we, there's a lot of good momentum created from the COVID crisis. How do we use that momentum to redesign our services, right? And embed some of the new changes and some of the innovative ways of doing work, as opposed to reverting to the old ways of doing work. Now, that's easier said than done because the natural tendency is to go back to our old ways. So we've got to work hard about how we redesign a whole lot of service delivery ways, processes, management processes, etc. I'll stop there. Thanks, Amanda.
Thank you so much. So, I mean, all of these learnings are extremely critical for health systems resilience, but also I heard also very important for everyday resilience, which is something that we may touch on towards the end of this webinar. I want to shift over to the Q&A portion of the webinar now and ask the first question from the audience for you all. One of you can choose to answer, or everyone can jump in if you feel that you can speak to this question. So the first is from Juan Carlos. Can you talk about the role of primary healthcare in making health systems resilient? Specifically, what are the top 3 approaches for strengthening PHC that contribute to the most in making health systems more resilient to shocks, specifically in low and middle income countries? Anyone want to take that on? I might turn to you, Krish, with your primary healthcare background. Yes.
I think a hell of an important question. Now, in our experience, primary healthcare is the place where 90% of our patient contacts actually happen. So it is really the place it is the key pillar of the health system. Yes, you know, all of the more complex stuff and the more kind of sexy stuff happens in specialized hospitals, heart transplants and all of that. But from a service rendering point of view, from a point of view of impact on health outcomes, primary healthcare cannot be emphasized enough. Right? It is the largest footprint of the health system. It is the place that touches into households and communities, right? And where the largest number of patient contacts actually happen. So I think the starting point is to recognize that and to really pay attention more and more to that level of the health system. The second point I'd like to make is redesigning the services in primary healthcare. So, you know, for decades, we've been largely focused on the bricks and mortar of primary healthcare. So largely working within the clinics and the community health centers, etc. Right? And now the global experience has been, how do you go beyond that and penetrate into households and families and communities? Right? And community health workers, who are the kind of foot soldiers of taking that on, is however important, and their impact has been shown by evidence in many studies, right, of how they can impact on health outcomes, and playing a role in prevention and promotion, playing a role in self-care, in adherence to treatment, etc. I think it was Maureen who spoke about the innovative ways of getting chronic medication to patients, right? And that's in COVID, we learned some very good lessons and tried some good things about how to do that to save patients coming in to the system. So I think I completely concur with the colleague who asked the question. I think huge area for a lot of potential and big leverage point for better impact in healthcare. And I'm sure there's much more could be said about it, but let me stop there. Thanks.
Thank you so much. We have a lot of great questions from the audience, so I'm just going to jump to another. So someone has asked about trying to maybe discuss a bit more of the difference between health system support versus strengthening. So if in procurement and community health worker salaries, there's a support system, but alone that won't strengthen it. What is the right balance between pandemic, I guess, in terms of pandemic preparedness? I don't know if that's a very clear question, but the difference between health system support versus strengthening. Anyone wants to speak to that?
I can have a first shot if you like. I mean, I think you articulated the difference there. So support in a way is a sort of short-term prop, whereas strengthening would be more akin to what we've been discussing as resilience, I think. So one of the big questions in pandemic outbreak response is you have vast amounts of money being thrown at the health system for one specific thing to support a health system to respond to the crisis. But that ignores two things. The first that Krish was talking about earlier, the need to plan to strengthen a system well in advance of a crisis. Otherwise, you're not actually strengthening the system. You might be supporting it for that limited period of time, but you actually have to invest for the long term. And second, it doesn't necessarily leave any legacy that can continue that support in a way that would be a strengthening facility. So in Sierra Leone, they established certain new structures for surveillance, for example, during the pandemic, but actually they have tried to retain those afterwards. So they've used disease surveillance officers that were trained for Ebola surveillance and response, have been repurposed, if you like, and now act as surveillance officers for any outbreak in local communities. And Maureen gave examples of how PEPFAR has contributed to sort of wider health systems strengthening. But I think it is important that we keep that difference in mind and that we continue to advocate for lower middle income settings, low income settings in particular, that the donor community does not only support a health system for a particular problem or crisis, but actually invests for the long term in its effective strengthening. And we've discussed various ways that we need to strengthen to build resilient systems, and none of it will be quick and none of it will be sort of bullet responses. It will take time.
Thank you.
And maybe if I can just jump in, just to add to Susanna's point, I think we need to do both. Use the funding that we have for disease-specific activities to strengthen the health system in a way that it can be more resilient for additional health threats. In addition to trying to get more resources, for strengthening the health system, including primary health care and really the community health workers and healthcare at the community level. I think that what Susanna mentioned previously about it being hard to measure creates a challenge when we think about funding health systems, strengthening and even resilient health systems. Most funders want to put money towards something that they can really have clear outcomes from. And I think this has been a challenge for years in terms of health systems, is what exactly do you measure and how do we know something is a strong health system or resilient health system? Recently, the WHO has implemented the Joint External Evaluation Measuring Tool to think about capabilities towards the international health regulations. And we realized that there are limitations to that tool in terms of countries' response to COVID-19. Some countries that were deemed to be quite strong using that tool had great challenges in responding to COVID-19. So where can we make some changes? How do we really measure the strength and the functionality beyond just saying that you have a strong health system, but is it able to actually function during the time of crisis as it is meant to or needs to respond to those crises?
Thank you. I feel that the responses have also answered a lot of the other questions around financing and measurements from our audience. I'm going to ask another question specifically around whether you can speak to some approaches that you would use in particularly in very fragile settings. So are there specific interventions that you would need to adapt when working in fragile settings? And can anyone from the panel speak to this question? I'll ask another question as well in case that's a bit of a difficult one. Do you see any digital solutions playing a role in shaping health systems to make them more resilient to climate and other shocks in particular?
I'll respond on the first one, Amanda, from the pandemic response work that we did. I mean, it is really difficult. I think, as we were saying, it's hard for flexible, adaptable responses. You can't put a blueprint in place. I think the big lesson of the West Africa and the DRC, actually, of Ebola responses and the COVID responses, is that you have to connect with people at the front line. And as an approach, that's quite different from the way pandemic response or crisis response usually happens. It's also different from the way crisis response in any fragile setting usually happens. There is usually a rigid structure and hierarchy that is put in place with different pillars, which different donors. Now, you need that coordination. You've got to have something organized, but within that, you have to be able to have a sort of bottom-up mechanism as well as the more top-down, because otherwise you potentially undermine your own response. And part of that is using embedded, local people. So we have colleagues who've been working in Madagascar in cyclone response, and people already very poor, but then being hit with a cyclone that takes away most of what the little that they had. And NGOs there was supporting community health networks who they had a relationship with. Now, the community health workers knew which communities were completely cut off and that they needed to reach them by boat, but they also, through their mobile phone networks, knew precisely what medical supplies they needed. So they were able to help mobilize and transport those resources to the communities that needed them most. Without a relationship and a connection with local people who have the local intelligence, it's pretty hard to respond effectively. So just to reiterate, that community level connection.
course. And unfortunately, that's, I think, all we'll have time for the question and answer section. Speakers, thank you all very much for your responses. And thank you all in the audience for joining us for such a rich discussion on health systems resilience, one that we can potentially have for many hours, I'm sure. To wrap up today's session, I want to give each speaker just 1 minute each to provide some final reflections on the way forward. And so I'll turn it over to Maureen first. Thank you.
Thank you so much, Amanda. So I think, really have just appreciated the rich discussion we had today. I think maybe for the way forward to focus on the need for building resilience requiring political, financial, and programmatic collaboration, coordination, and action. And I think from the political standpoint, it's really important to ensure that as we're building resilient health systems, we acknowledge that infectious disease threats are recognized as important to many sectors beyond health, and not just health, but including finance, economy, education, tourism, and that governments prioritize funding for preparedness and resilience through strengthening health systems infrastructure between crises. And that it's important that also there are partnerships built with the private sector and academic institutions as well. And this has to happen. These trusted relationships need to be built in advance of the crises so that they can be you can draw upon them when the crisis hits. We mentioned this previously, but public health challenges have frequently experienced a cycle of panic and neglect, I think is how it is referred to by policymakers and implementers. So a surge of funding to combat a pressing issue, but then a drop off after the immediate crisis. So trying to ensure that there are sustainable financing mechanisms for public health systems, that they can work during the routine, normal, day-to-day times, as well as being able to be drawn upon when health crises occur. We have seen this with PEPFAR, that we've had sustained funding to combat HIV/AIDS for 20 years, and that has strengthened underlying health systems. So not only saving more than 25 million lives from HIV/AIDS, but also making the health systems more resilient to other health threats. And so we would hope that this can be seen as an example, and that we can use and leverage the health systems that PEPFAR continues to strengthen to also make these health systems in the partner countries more resilient to health threats as they occur in the future.
Thank you, Maureen. Over to you, Krish, for your reflection, and then to Susanna to end us in the webinar.
Thanks, Amanda. So in conclusion, I would just like to say a few quick things. I think that first of all, social determinants of health, right? I mean, if as a health system, and even our argument for a resilient health system, the whole purpose of that is to improve health and well-being and improve outcomes at that level. So we as health leadership have to pay attention also to the social determinants of health. And, while adversity is important in whatever shape, size, and form it comes at us, there's an underlying amount of poverty, abject poverty, unemployment, etc. in some of our countries, including in South Africa, being one of the most unequal in the world, right? Those have to be addressed in whatever way resilient health systems and society generally can do. So that's the first point. I think also we must be careful about resilience not becoming a swear word, right, where it is interpreted as empty management jargon, right, that's thrown around, and we expect frontline staff to suck it up all and just absorb relentless pressure on a day-to-day basis that comes at them. So it has to be backed up with genuine, empathetic, responsive leadership at all levels, and not only within the health system, but political leadership included, right? That we are with the staff in the trenches trying to strengthen the health system and improve outcomes. So we must just be careful, because sometimes it's easy for cynicism to develop. I mean, could you imagine the situation in Gaza at the moment and talking to health workers to be resilient when half the hospitals have been bombed, ambulances, etc. So it's an important concept that can go pear-shaped if we are not careful about how we address it systematically. Thanks very much.
Thank you. Over to you, Susanna.
Thanks. Yeah, I agree with all of the previous comments. Just to add two things, I think from my perspective, two critical things. One, Krisha just touched on commitment at all levels of building distributed leadership skills to enable the system to be flexible and adaptable. And related to that, embed ways of working that involve frontline health workers and community groups to build that trust and co-develop actions. And there are emerging guidelines and strategies for this. I mean, we've discussed some in this call, but there are others which we could perhaps share resources of afterwards. We still lack measures for this, as Maureen highlighted again. We've got current work ongoing with an NIHR-funded consortium called Building Partnerships for Resilience, PARES, which is trying to distill common effective approaches to engage communities in health sector resilience building and develop measures for that. So we hope that in a couple of years' time, there'll be more to share on that. There's also growing commitment to sharing ideas and approaches to how you strengthen health systems resilience in response to climate change in particular, and a range of platforms emerging to do that. So I think the future is partly in working together and openly sharing what works and what doesn't work. And this webinar is a great example of doing just that, I think.
Thank you. Wonderful. This concludes our webinar on building resilient health systems in a changing world. Thank you all for joining, and take care.